So I'll begin with, I'll quickly go through it. I have short of time, this is my disclosure. Just a little tribute to my mentors, to anyone who helped in my career navigate through this day. So a beautiful saying by Isaac Newton, if I have seen further enough today, is by standing on the shoulder of giants. So thank you to all. A couple of options we all know. I've been listening since morning, from BTB to hams to quads to allografts. They all have their pros and cons. So whenever I talk about this thing, this is the kind of reaction I get. Well, why? Can we do it? What promise does it hold? Graft choices we all have been contemplating about for the last couple of decades. There's no one suitable ideal graft. Every graft has downsides. We've been studying back in Faisalabad from quads tendon to hamstrings to peroneous longus tendon, and we have been studying them meticulously to see how they're performing inside the tunnels, what are the re-tears rate, what are the return to sports criteria, and what is the donor site morbidity. A few steps to harvest any graft. I proceed with examination or anesthesia. It really helps elucidate a lot of findings that I'm unable to see and elicit in clinic. So it changes my graft options to procedures from adding an augmentation in the form of fiber tape or in the form of adding an extra-articular tenodesis. Step one, just marking my incision to the lateral malleolus. I apologize for this video, a little distorted and inverted. So I'll start beginning on the lateral malleolus, just mark my site, and then I'll proceed with my incision, which is just a 1.5 centimeter incision. And 1.5 centimeter incision, just 2.5 centimeter proximal to the lateral malleolus and just 1 centimeter behind it. So proceeding from that, I will just identify the peroneous longus, which is quite tendinous, thick, gorgeous tendon with very less soft tissue attached to it. And I'll begin whip stitching the tendon right next to it, and then after I put a couple of stitches on, I get hold of it, and then I proceed on to identify peroneous brevis, which is right behind it. It's peeking right from the behind. You can see it with a little bit and little soft tissue attached to it. It's not very mobile as compared to peroneous longus. Positioning of the foot is very crucial. For me, I just keep it in 5 degrees of valgus just to keep the tension on the peroneous longus, and it really helps tension the graft before I proceed for the next step, which is even more important to harvest peroneous longus. Of course, it is a distal tenodesis with a peroneous brevis, and it really matters for a smooth harvesting and to reduce the donor site morbidity later on. I double check my tenodesis. You can see I make sure that it does not come off when I put in distal tenodesis, and it's solid and stays there. Then I proceed for the next step. Next one is just separating the distal part of the peroneous longus just to see and feel the tendon. You see the excursion, you see tendon coming off clearly, and it's the right time to introduce my stripper inside. So introducing the stripper, checking it goes smoothly, holding the tendon and keep a hold of it so that all the way up to the end point. So very important when we are harvesting and taking the graft out, just to stop 4.5 centimeter proximal to the head of fibula, just to protect the peroneal nerve. Next up, you can play with the graft whatever the way you want. You can double it up. You can make 3 stands. You can just go for whatever the way you want. It's all about the diameter and the technico-facial you are using from all inside to the standard one. We have been studying the graft diameters of both peroneous longus and quadruple hamstring. If we double up the peroneous longus and we quadruple the hamstring, the kind of mean diameters we have so far, and with the goal of 8.5 minimum diameter with each, and I don't accept anything less than 8.5. With literature coming up with a couple of evidences, and they are constantly growing, and it's enough evidence to just consider peroneous longus. It's not the graft of choice, of course, for now, without any long-term trials, but still it holds promise for the ACL reconstruction. Extensive rehabilitation starting day one, aggressive ankle rehabilitation. It's very important to just keep the patients on track. Ankle balance and eversion strength exercises beginning from day one. It's a routine practice in patients declaring them for the sports. I do check all of the strengths and ankle when we proceed for the single leg hop testing, and most of the patients, none report any discomfort and disability when we are going back in the ground after 6 to 8 months of the surgery. Studying the graft behavior inside the tunnels has been excellent and showing promise. You see his 2 years post-op graft healing has been amazing with very less issues at the knee and very limited donor site morbidity at ankle. The next question was whether there are specific athletes in which we should offer the graft. We studied all the athletes coming from different sports, starting from contact sports to pivoting sports. One of the national players treated with the peroneous longus ACL reconstruction, back and ground, performing internationally, representing Faisalabad. Another player, soccer player, playing from the same foot from which the graft was taken, no significant issues, no morbidities, and he's been perfectly fine so far. He's 4 years out of the surgery. National table tennis champion from Faisalabad, treated from the same graft, a peroneous longus, ACL reconstruction, back and ground, and recently national games, he reclaimed his title once again. Pivoting sports like cricket, soccer, players are performing pretty fine, studied peroneous longus with very limited and very promising return to sports. National swimming champion under 20, representing Faisalabad after ACL reconstruction with peroneous longus autograft, and even in recent national games, he also reclaimed his title once again. National basketball player performing perfectly fine after peroneous longus ACL reconstruction. Another very interesting patient who came to me for the ACL reconstruction with prior hamstring ACL reconstruction on the right side. I offered him a peroneous longus autograft on the left side, and this is me checking his outcome 8 months down the line. He is reporting excellent outcomes on the left side. The knee was treated with the peroneous longus. Maybe it was due to the very limited harm and damage done to the knee. Advantages of peroneous longus to keep in mind, starting from the length to diameter, tensile load, harvesting time, of course very limited adherence with it, so it takes less time with very limited collateral damage. If you keep all the pros and cons in mind, donor site morbidity has been studied extensively and it's very promising, excellent outcomes at knee and ankle. Graft healing as tunnel is excellent, but re-tear rates, we're studying that and still a lot of data to come out on that. Pearls and pitfalls to keep in mind before harvesting peroneous longus. So just the things I discussed for a successful and smooth harvest. One other striking comparison of peroneous longus with hamstring from Faisalabad has been recently been accepted by JBJS, and it will be out soon, and it will help clearing out a lot of confusions on return to sports and graft healing in the tunnels and the re-tear rates. Literature has been fraught with all the evidence, and it's been studied extensively for the last 2 decades, but still a lot more to come. A lot of work is being done, and still we have to have more long-term RCTs to be sure that the graft is performing well, and it is the choice of graft for primary ACL reconstruction. We have been presenting all this data around the globe of all the societies, from American Academy of Orthopedic Surgeons in San Diego, in Chicago, and last year in CCOT in Malaysia. Thank you very much.